The program in eMTM, Enhanced Medication Therapy Management, that we offer has to do with identifying components of medications that can cause adverse drug events in elderly, mostly in the elderly. So the components would be, for example, if somebody's on 10 medications and 3 or 4 of them may cause sedation, then we quantify that and say they have a sedation risk of 8 or whatever. We also look at anticholinergic risk, which is drugs that make you dry, like a Benadryl, dries your nose, but dries your mouth, dries your lungs, dries your bowels, and dries your brain. And that can cause people to be prone to fall and then go to the ER and then the hospital, elderly people. So we look at that. We look at many drugs cause dysrhythmia in the heart. They affect some of the ion channels in the heart, and they can, if they build up, they can clog the channels a bit, and people go into have a dysrhythmia and have a heart problem and actually can die. So we look at that. We look at other actions of medications. For example, if you have somebody on 10 medications and they're taking 3 of them that go through a particular pathway to get cleared from the body or excreted, then you can have think of a pathway as like a parking space. And there's only so many parking spaces in the intestine and the liver for these drugs to get metabolized or water solubilized, so they go to the kidneys. And if you have 3 or 4 drugs in that pathway, the drug that has the highest affinity to those parking spaces will get in there first and clog them all, and the other drugs you're taking will just go in and not get metabolized, and you'll be full strength for hours. And so you get what's called an unintentional overdose. So we look at a lot, and that construct is called competitive inhibition. So we look at competitive inhibition also. So in other words, we look at sedation burden, we look at anticholinergic burden, can they fall, will they fall? We look at the heart effect, we look at the competitive inhibition, and we also look at information on relative risk of adverse events that is published by the FDA for different drugs, and we put it into a system and do some statistics on it, and we can show the pharmacist with these 10 drugs for Mrs. Jones, think about these types of adverse events or side effects that she may be exhibiting. So that's kind of new. That's new information, and people haven't been doing that. And the reason that it's different is because pharmacists and physicians, electronic health records, for about 40 years have had the same system of one-to-one drug interaction. And it just says, when you see these 2 drug interactions, you may get whatever side effect. But it doesn't tell you what's going on underneath, why. And if you have somebody on 10 meds, there's no way you can really keep track of that. So our system that we've introduced into the eMTM project we're doing does what we call multi-drug simultaneous analysis. I think the future of eMTM, first let me say thank you to the CMS for doing this, because they have enabled us to have a crucible or a petri dish of experiment to try and come out with something where pharmacotherapy affects part A and B. In other words, the expense for medicine, medical and hospitalizations. And heretofore, pharmacotherapy has been in its own silo over in part D, and A and B have been in their silo. So what CMS is doing with this change for value-based care is they're bringing everything together, and it all counts. And that's going to be exciting, whether it's in Part D or whether it's in a Blue Cross plan. Everyone's going for value-based care, which is optimized care.